ganglion cell and retinal function in a mouse model of normal tension glaucoma. I have no conflict of interest to declare. Glaucoma is characterized by chronic progressive degeneration of retinal ganglion cells and their axons. And once the optic nerve is damaged, it cannot be regenerated. The main treatment for glaucoma is to lower intraocular ocular pressure, IOP, but there are many cases in which the disease still progresses even after sufficient IOP reduction. It is now known that various factors other than IOP, such as oxidative stress and degrading neutrophic factors, are involved in the pathogenesis of glaucoma. Therefore, it is necessary to consider new neuroprotective treatments, which could be effective for glaucoma therapy. In this study, we focus on neutrophic factors. There are multiple types of neutrophic factors and their receptors. And TrkB is the most highly expressed in the retina and optic nerve. It is involved in nerve cell differentiation and growth, and has roles in synapse formation and neuroprotection. In this study, we focus on TrkB receptors. TrkB receptors do not activate downstream signals on their own. It requires BDNF, which is its ligand. Binding of BDNF to TrkB receptor forms dimers and activates downstream signaling, which leads to neuroprotection and axon elongation. In our experimental setting, the size of full-length TrkB is beyond the size that can be incorporated into AAVs, and it is not practical to constantly supply the ligand to activate TrkB signal. Therefore, we attempt to create a gene construct that is small enough to be packaged into AAV in our setting, and that can activate downstream signal with that ligand. TrkB has a kinase domain in the intracellular region, which is important for their activity. Here we have created two types of molecules, one with only the intracellular region and the other with the intracellular region and the transmembrane region. Both of them contain the kinase domain, and they are small enough to be packaged into AAV in our system. We examined if these two molecules activate the downstream signaling of TrkB, and unfortunately, they did not activate downstream signaling in cultured cells. The reason for this may be that normal TrkB receptors are expressed at the plasma membranes, but our molecules may not be translocated to the plasma membranes after synthesis. Therefore, we attach a farnesyl group to the intracellular region of TrkB as a membrane targeting signal. And we found that iTrkB was localized to the plasma membranes in cultured cells and successfully activated downstream signals of TrkB. To summarize so far, TrkB normally activates downstream signaling by binding to its ligand, BDNF. Our newly developed construct, FY-TrkB, activates downstream signaling without BDNF. We next prepared an AAV vector with FY-TrkB and examined its neuroprotective effects in normal tension glaucoma-like model mice. GLAST is a glutamate transporter expressed in mural cells and transport glutamate and cysteine into cells. Glutamate is a neurotransmitter, but it is also neurotoxic at high concentration. In addition to oxidative stress, glutamate toxicity is thought to affect retinal ganglion cell death in grayscale mice due to insufficient removal of extracellular glutamate. As you can see, there is a loss of RBCs and thinning of the inner retinal layer in grayscale mice. You can also see optic disc cupping and optic nerve atrophy, which are similar to human glaucoma. There is no difference in IOP between wild-type and grayscale mice. This is the experimental protocol. 2 weeks old growth scale mice were injected intravitreal with AB FI track B or AB control vector. And intraocular pressure, optical coherence tomography, and berries were examined at 3, 5, and 12 weeks old. We checked intraocular pressure of grayscale mice treated with AB FI track B or AB control at 3, 5, and 12 weeks old. But there are no significant differences in all groups. We treated grayscale mice with AB FI track B and counted the number of RDCs at 3, 5, and 12 weeks. These are showing immunostaining with an RBPMS antibody in flat-mounted retinas. You can see that at 5 weeks and after, the RDC number was reduced by about 40%. But AB FI track B treatment increased the number of RDCs. These data demonstrate that RDC death is reduced with AB FI track B treatment in a mouse model of MTG. Next, we examined in vivo retinal morphology using OCT. The ganglion cell complex was thicker in grayscale mice treated with AB FI track B than in those treated with AB control. We also measured visual responses using MFARGs. The response was higher in AB FI track B treated mice than in AB control treated mice. These data indicate that intravitreal injection of AB FI track B protects RDCs from death and escalate to retinal degeneration and functional decline in grayscale mice. Conclusions. Foreign-related intracellular domains of the track B constitutively activates downstream signaling without ligands. AB FI track B has neuroprotective effect in the mouse model of normal attention glaucoma. I would like to thank everyone who contributed to this project. Thank you for your attention.
Greetings from Chandigarh, India. I'll be speaking on glaucoma in preterm infants with no retinopathy of prematurity. So there are no conflicts of interest. With the improvement of neonatal intensive care services, there has been increased survival of preterm infants, especially in our country. So with the increase in survival of these preterms, the challenges associated with the management of the associated ophthalmic manifestations also increased. ROP is the most commonly reported ocular condition in these preterms, and if it coexists with glaucoma, it can pose serious implications on the vision. However, some preterm babies may present with developmental glaucomas with no coexisting retinopathy of prematurity. So we intend to report the incidence and management outcomes of neonatal onset glaucoma in this cohort of preterm infants who had no ROP. We took consecutive infants who presented to us over a 5-year period between July 2015 to June 2020 and included all the infants who were born at a gestational age of less than 36 weeks and who had no ROP on any visit. So we suspected glaucoma by any two of the following, that is either increase in corneal diameter and corneal haze, IOP more than 16, or optic disc cupping. Glaucoma surgery as appropriate was done and a minimum of 6 months of follow-up was taken. All these infants, they underwent examination under anesthesia, which included details of the cornea, that is the cornea clarity and the corneal diameter, the anterior segment details, the intraocular pressure, angle details, disc status if visible, pachymetry, and the axial length. The glaucoma was characterized according to the CGRN classification, and the outcome measures included the cornea clarity, IOP, axial length, and the visual acuity. So out of a total of 1,720 patients of childhood glaucoma who came to us during this 5-year period, 121 were of neonatal onset. 1 were preterms, 90 were terms, and out of these preterm infants, 7 were the ones who had no ROP. So these were included in our study. Out of these 7 infants, 2 had primary congenital glaucoma, out of which 1 had bilateral lens subluxation, 2 had CEU, 2 had ARS, while 1 had iris hypoplasia with coloboma. So if you look at the baseline characteristics of these infants, the baseline IOP was mostly in the 20s, and the asterisk indicates that they were on some form of treatment at the time of recording of the IOP. So 10 eyes of these infants, they underwent CTT, while 3 eyes underwent a goniotomy. 1 eye was excluded from the study as it had an anterior staphyloma and was PL negative. So the cornea clarity at presentation was in most of them it was 3 or above, while at 6 months follow-up it was around 1 or 2 in most of the infants. The second surgery was for IP control. It was needed in 4 eyes. That is, a goniotomy was done post cornea clearing after a combined trab-on-trab, and 2 eyes needed an optical iridectomy, presence of central scar. If you look at the mean parameters, at baseline, the gestational age was around 30 weeks, the birth weight was around 1501, IOP was around 19.6, and the exit length was 17.41. The mean age at which first surgery was done was 6.14 weeks, and the mean age at which the second surgery was done was 24 weeks. IOP at 6 months follow-up was 17.3. So the cornea clarity mean was 2.93, and these are the images of the infants at the time of presentation. And the cornea clarity at 6 month follow-up was 1.482. That is the mean. So there was a significant improvement in the cornea clarity as shown in the images. So congenital glaucoma, it accounts for 4 to 18% of childhood blindness. And secondary glaucoma has been studied, it has been reported in the literature, and it is known to be a complication of ROP in preterm infants. It is also reported in India, in Hyderabad, which was a large study which was done by Sentelis et al., and they reported the prevalence to be around 1.36%. However, congenital glaucoma in preterms without ROP is a rarely reported entity. So in our cohort of patients, 4.7% of all these neonatal onset glaucomas were in preterms who had no ROP. And challenges due to the associated systemic problems do exist, while early diagnosis and management can provide a fair outcome. So, thank you so much.
The topic of my presentation is newborn glaucoma. Are we missing infections? I have no conflict of interest to declare. Our study was conducted in a tertiary care center in northern India, which caters to about 11 million population of the country. So the intrauterine infections, they may affect various structures of the developing fetal eye, and it may present with glaucoma and cataract in newborns. The etiology of glaucoma in infection is supposed to be trabecular dysgenesis or persistent viral damage to the trabecular meshwork. The purpose of our study is to report the incidence of rubella positivity and early treatment outcomes in a cohort of babies with newborn glaucoma. Our study was cleared by Institutional Ethics Committee, and the infants who were diagnosed with glaucoma aged less than 4 weeks who presented to our center between October 2017 and December 2018, and those who had at least a 12 months of follow-up were included in the study. The rubella IgM titers were measured for all the babies who were diagnosed with glaucoma, and rubella positive group was compared with the rubella negative group. The presenting features such as intraocular pressure, corneal clarity, corneal diameter, lens status, axial length were noted. So a total of 27 patients were diagnosed. Out of those, 7 patients tested positive for rubella IgM antibody, while 20 patients tested negative for rubella IgM antibody. So 13 eyes of those 7 patients and 34 eyes of 20 patients were included in the study and compared. At presentation, the age at onset, age at presentation, and intraocular pressure had no significant difference between the two groups, while the rubella positive babies, they had a worse corneal clarity, smaller axial length, smaller corneal diameter, and the coexistent cataract group were noted only in the rubella group. Systemic associations were also noted in rubella positive babies. Heart disease were noted in 3 out of 7 patients, while hearing deficit was noted in 1 out of 7 patients. The outcome measures, the cornea cleared significantly in patients who were rubella negative as compared to those who were rubella positive, despite comparable IOP reduction. As we can see in this outcome data, the cornea clarity at 6 months, 1 year was statistically significant in rubella negative patients. So as we can see in this slides, these two patients on the left side of the slide, their cornea clarity improved after 1 year of follow-up, while the two kids who are on the right side of the slide, their cornea clarity did not improve much despite comparable intraocular pressure reduction in both groups. Now, additional procedures which were required were, in the rubella positive group, 7 out of 13 eyes required additional procedures, which included lens aspiration, optical iridectomy, evisceration and prosthesis in one unsightly blind eye due to anterior staphyloma, while in rubella negative group, 6 out of 34 eyes required additional procedures, which included optical penetrating keratoplasty and optical iridectomy. Now, the commonly thought of ocular features in congenital rubella syndrome are cataract and salt and pepper retinopathy. The glaucoma is a less commonly recognized manifestation, but it is very important to suspect rubella for the prognostication of disease, and we need to explain to the parents that the disease has an infective nature rather than a hereditary nature, and to screen for the systemic associations like cardiac disease and hearing impairment in rubella positive babies. To conclude, the newborn glaucoma in rubella positive cases are phenotypically different. They have smaller eyes and a persistent corneal opacity, which is not related to raised intraocular pressure, as despite comparable intraocular pressure reduction, the corneal clarity did not improve much as compared to the rubella negative group. So the cases of unrecognized congenital rubella infection might be mistakenly diagnosed as an intractable congenital glaucoma, and any glaucoma with a smaller eye should raise the suspicion of glaucoma with rubella. Thank you.
I'm Dr. Chen from the Taichung Veterans General Hospital in Taiwan. Today, I will present data from the retrospective cohort study to evaluate the association between retinitis pigmentosa and an increased risk of primary angle closure glaucoma. My study is a population-based study using the National Health Insurance Database in Taiwan. I have no conflict of interest to declare. Retinitis pigmentosa is a genetic disorder that involves a breakdown and loss of photoreceptor cells. Patients typically lose night vision and then lose peripheral vision, eventually leading to blindness. Looking at previous studies, a study in Canada revealed that among patients with RP, 1.03% had PSCG. In China, 2.14% of RP patients had PSCG. A study in Nepal found that among patients with RP, 2.13% had angle closure glaucoma. Another study in Taiwan showed 1.31% of RP patients had angle closure glaucoma. The prevalence of PSCG among RP patients is low. Therefore, we have a question. Is there a real association between RP and PSCG, or the relationship is only coincidental? Previous studies demonstrated inconsistent answers. Besides, if there is a real association between RP and PSCG, the IOP elevation due to angle closure may aggravate the visual impairment in RP patients. Therefore, it is important to investigate the relationship between RP and PSCG. So, I conducted the population-based cohort study using the whole population database from 2001 to 2013. From the database, I chose a RP group and a comparison group. The two groups are 1 to 4 matched on age, gender, and index year. Using a long study period of 13 years, the two groups were compared in their cumulative incidence of PSCG and hazard for PSCG. Some confounders were adjusted when we investigated the association between RP and PSCG. The confounders are age, gender, hypertension, diabetes, hyperlipidemia, and chronic kidney disease. Now, I want to show you some of my results that I believe you will find interesting. This table shows the characteristics of the RP group and the comparison group. The two groups are well matched on age and gender. As you can see, the RP group has a significantly higher prevalence of diabetes, hypertension, and hyperlipidemia than the comparison group. During the follow-up period, the cumulative incidence of PSCG is significantly higher in the RP group than the comparison group. Moving on to this table, after adjustment of confounders in a cupped regression, the RP group still has a significantly higher risk of developing PSCG. The adjusted hazard ratio is 2.04. Discussion. Why would there be an association between RP and PSCG? Previous studies provided some theories. Patients with RP might have small eyes, cataract, or lens subluxation, which are all predisposed to PSCG. To test these hypotheses, we further adjusted cataract and lens subluxation in the multivariate cause regression analysis. We found that RP group still had a significantly higher risk of developing PSCG. The limitation of our study is we do not have information about ocular biometry in our database. Therefore, we could not adjust the effect of small eyes. Further studies will be needed to include this variable. My conclusion is those who suffer from RP will be at a significantly higher risk of PSCG. If you understand and accept that there is a real association between RP and PSCG, you will understand the need of timely intervention in these susceptible eyes. Thank you for your attention.
My name is Jungwon Shin from Asan Medical Center, Seoul, Korea. NAION is the second most common optic neuropathy and the most common type of non-glaucomatous optic neuropathy in middle-aged patients. Pathogenesis of NAION may be related to the transient non-perfusion or hypoperfusion within the optic nerve head. The main source of blood supply to the optic nerve head is the short posterior ciliary artery. Therefore, SPC circulation may be reduced in NAION patients. Glaucoma is the most common type of optic neuropathy, and its pathophysiology may be also related to the vascular insufficiency of optic nerve head. Recent study found an entity called choroidal microvasculature dropout in glaucoma patients using OCT angiography. It turns out CMVD is a true filling defect of peripapillary choroidal circulation according to ICT angiography. Therefore, CMVD may represent vascular insufficiency of optic nerve head. Because choroidal circulation is downstream from the SPCA, it is plausible to expect to find CMVD in NAION eyes. However, CMVD in NAION eyes has never been explored. Therefore, we hypothesize that CMVD is expected to be observed in eyes with NAION because both diseases may share the similar origin of vascular impairment. but the clinical features of CMVD in NAION eyes may be different from those in the eyes with glaucoma. In the present study, we investigated the presence of CMVD in eyes with NAION and compared the clinical characteristics of CMVD between eyes with NAION and normal tension glaucoma. We designed a retrospective cross-section study and recruited subjects with NAION, NTG, and healthy control. Common inclusion criteria are shown in this slide, and the definition of NTG follows a previously reported criteria. Also, the definition of NAION follows widely accepted criteria. We only included chronic phase patients after 6 months from the onset of NAION. AION patients were excluded based on ESR and C-reactive protein levels. Because age and visual field damage can contribute as confounding factors in detecting CMVD, these factors match between eyes with NAION and NTG. CMVD was evaluated within the ERA-PPA and defined as a complete loss of microvasculature on OCT choroidal image. CMVD characteristics such as area, angular width, and location were measured. Our study included 27 NAION eyes, 27 NTG eyes, and 27 healthy controls. We observed CMVD in 55% of NAION eyes, 74% of NTG eyes. The area and angular width of CMVD were significantly greater in NAION eyes than NTG eyes. This frequency distribution plots show different location of CMVD between two groups. In NAION group, CMVD was distributed relatively wide range and was frequently located at temporal area. In contrast, in NTG eyes, CMVD was distributed relatively narrow range and was frequently located at intertemporal region. To find out the factors associated with the discrimination NAION from NTG, logistic regression analysis was conducted. In multivariable analysis, larger CMVD area and CMVD closer to the temporal location were associated with diagnosis of NAION. These representative cases show larger size, wider angular width of CMVD involving temporal area in NAION eyes compared to the NTG eyes at a similar pattern and degree of visual field damage. These cases show same story in eyes with much less visual field damage. In summary, we found the CMVD presence in 55% of NAION eyes, and CMVD characteristics were different from NTG eyes. Among various parameters, the area and location of CMVD may be important predictor of distinguishing NAION from NTG. Different characteristics of CMVD that we found in this study using OCTA may provide an alternative approach to differentiate glaucoma from NAION. Thank you for your listening.
Hello everyone, my name's David. Thank you for listening. This is a comparative study of 2-year outcomes for Hydrus microstent versus iStent inject when combined with cataract surgery. Minimally invasive glaucoma surgical devices, or MIGS, are one of the largest areas of interest and research in glaucoma treatment over the past decade. The purpose of this study is to compare the 2-year outcomes of the two most common, Hydrus and iStent, head-to-head when combined with cataract surgery. To date, there have been no such comparisons reported. The Hydrus microstent is a Schlemm's canal scaffold. It's inserted ab interno through the phaco wound. It's an 8mm long nitinol crescentic device that's inserted into the canal, expanding it to increase aqueous outflow. The iStent inject is a trabecular meshwork bypass device, which is also inserted ab interno through the phaco wound. They are paired heparin-coated titanium stents, which traverse the trabecular meshwork, increasing aqueous outflow. Comparing the Hydrus pivotal, or Horizon, and iStent pivotal trials, results are very similar. The Hydrus pivotal showed an unmedicated IOP reduction of 7.6 millimeters of mercury and the iStent 7.0. Both trials had very similar methodology with medication washout periods. The COMPARE trial, which is a prospective randomized controlled trial comparing Hydrus versus first-generation iStent, found no significant difference in IOP reduction, but that medication usage was significantly lower in Hydrus at 3 and 12-month follow-up. Studies with comparative pretreatment IOP levels have found between 18.5 to 25.6% reduction post-combined phacoemulsification and mixed devices. There is a definite trend towards higher pretreatment IOP having greater IOP reduction. Numerous studies have all reported medication reduction for both devices to be between 1.0 and 1.5 medications. This is an observational study analysing anonymised data from the FIGHT Glaucoma Blindness Registry, which was captured during routine clinical practice. The FGB registry is part of the SaveSite Registries program, which is a web-based platform available worldwide. It captures clinical data for the purpose of audit and research into real-world outcomes of glaucoma treatment and practices. Treatment decisions are at the discretion of the treating clinician and patient. Each patient has baseline demographic and phenotypic data recorded. Then each subsequent visit has mandatory fields, including IOP, visual acuity, and medical treatments, and adverse event. The inclusion criteria for this study are open-angle glaucoma, either primary or secondary, or normal tension glaucoma, or ocular hypertension, that had undergone combined phacoemulsification and Hydrus or iStent inject insertion, with a minimum of 24 months follow-up data available. Exclusion criteria were any prior incisional glaucoma surgeries or intraoperative complication at time of cataract surgery. Each surgeon included consecutive cases meeting these criteria, and follow-up was performed as routine post-operative care. Only cases where all IOP measurements were taken using Goldman applanation tonometry were included. The primary analysis was a comparison of mean 24-month post-procedure IOP of each group to detect a difference of 1.5 millimeters of mercury between the two groups. Baseline characteristics between the groups were compared using t-tests and chi-squared tests as appropriate. Significant differences in baseline characteristics were found, so propensity score matching, ratio of 1:1, using logistic regression based on the preoperative IOP, preoperative number of medications, age at procedure, Humphrey visual field mean deviation, and gender was then used to help account for these differences. The initial cohort, the IOP, the mean number of medications, and visual field mean deviation were all significantly higher in the Hydrus group. We suspect that this is due to the perception that Hydrus has greater efficacy and is thus chosen for more advanced glaucoma. After propensity score matching, the only variable that remained significantly different was visual field mean deviation. For Hydrus, IOP reduction equated to 12.6 millimeters of mercury and iStent 17.7% reduction. Reported range is between 18 to 25 for both Hydrus and iStent inject. 0.5 fewer medications were used in Hydrus and 1.0 fewer in iStent inject. iStent inject was also superior for both complete and qualified success at all IOP levels. However, this was found to be non-significant. As this Kaplan-Meier shows, the Hydrus group has higher rates of achieving qualified success at some point during the 2-year follow-up period. However, the iStent group was more likely to have achieved complete success. This was also non-significant. There was a low rate of ocular adverse events. There were no significant differences between the two groups, and there are higher rates of early, 0 to 1 month, loss of best-corrected visual acuity greater than 2 lines in the Hydrus group, but these recovered. There were no cases of endophthalmitis or significant anterior uveitis. 24-month outcomes of combined phacoemulsification and either iStent inject or Hydrus showed sustained IOP reduction with a good safety profile. There was no significant difference in IOP outcomes between the two groups. However, our results indicate that there might be a small additional reduction in glaucoma medication usage following iStent inject when compared to Hydrus. These differences could be further studied with the randomized controlled trial. Thank you very much for listening.
Hello everyone, my name is Rashi Rajput and I'm very thankful to World Glaucoma Congress for giving me this opportunity to present my work. The topic of my presentation is antibody-mediated neutralization of neuroserpin exhibits a retinal ganglion cell and optic nerve axonal damage in experimental glaucoma. Before starting this presentation, I would like to declare that there is no conflict of interest within the authors. As to start with the neuroserpin introduction, it is a serine protease inhibitor which is commonly expressed in the neuronal tissues like retina and brain. Neuroserpin majorly inhibits the tissue plasminogen activator, TPA, activity of forming plasmin from plasminogen and suppress the proteolytic activity of plasmin. As shown in the diagram, the most important part of the neuroserpin molecule is the reactive site loop, which binds to the TPA or plasmin to inhibit their activity. And in that way, neuroserpin protect neurons against the damage by overexpression of plasmin in the disease condition. Studies showed that the neuroserpin deficiency can cause increased inflammation in the ischemic brain injury, whereas neuroserpin overexpression was found to be protective in the retina in an acute ischemic model. Our group's pilot study showed that in neuroserpin activation in human and animal glaucoma model inhibits the plasmin inhibitory activity. And in this presentation, I'm showing the possible effect of neuroserpin neutralization on retina and optic nerve tissues in experimental glaucoma condition. While conducting this study, we performed weekly intraocular injections of microbead for 8 weeks in the mouse eyes to elevate the IOP and induce glaucoma, with the intravitreal administration of neuroserpin antibody and IgG as a positive control. After 8 weeks, we recorded the PSTR amplitude for the functional analysis and harvested the tissues like retina and optic nerve for the structural analysis. That is the H&E staining for retina and toluidine blue staining for optic nerve cross sections. Proteolytics evaluation was done by performing the Western blots and plasmin inhibitory activity assay on retinal samples, and at last, immunofluorescence evaluation of retinal tissues. Firstly, in this figure, the functional analysis showed the decrease in the average PSTR amplitude of the mice eyes with experimental glaucoma, and it is reduced in glaucoma with anti-neuroserpin treatment as compared to the sham control eyes. The glaucoma with IgG showed almost a similar trend as only glaucoma. Their quantification validated the significant loss of amplitude in glaucoma with IgG, and glaucoma with anti-neuroserpin in comparison with control. Further structural evaluation of retina stained with H&E showed the loss of RGCs in glaucoma and glaucoma with IgG, with further reduction in the glaucoma with anti-neuroserpin treated retina as compared to the control retinal sections. The optic nerve cross sections stained with the toluidine blue indicate the reduced axonal density in the tissues harvested from the mice with glaucoma with IgG, and glaucoma with anti-neuroserpin treatment in their eyes compared with non-treated controls. Secondly, the proteolytic evaluation demonstrated significantly reduced plasmin inhibitory activity in retinal samples harvested from induced glaucoma and glaucoma with IgG treated mice, and it was noticeably absent in the glaucoma with anti-neuroserpin treated retinal samples. To understand the effect on the cellular mechanism, we have checked the expression of some autophagy markers, that is Becklin-1 and LC321, by performing Western blot. We noticed that the significantly elevated expression of Becklin-1 and LC321 in the retinal samples of glaucoma and glaucoma with IgG treated mice eyes, which further significantly increased in glaucoma with anti-neuroserpin treated mice eyes as compared to control retinal samples. Thirdly, in immunofluorescence analysis, we have checked the IBA expression demonstrating the microglia activation in the retinal sections. The results showed that the IBA stain activated microglia mostly in the inner retinal layer of only glaucoma and glaucoma with IgG treated mice eyes. Microglia activation was higher in glaucoma with anti-neuroserpin treated retinal tissues. This explains that the neuroserpin neutralization is causing more stressful condition in the eyes with experimental glaucoma. Hereby, it is concluded that there is increased structural and functional deterioration in the retinal tissues and optic nerve in the glaucoma eyes subjected to neuroserpin neutralization. It is also lead to mostly absent plasmin inhibitory activity accompanied with elevated Becklin-1 and LC321 expression in the retinal samples. Microglia activation, as quantified through the IBA expression, increase in the inner retina, mostly in the inner plexiform layer in glaucoma eyes with neuroserpin neutralization. Therefore, this study demonstrated the neuroserpin plays a key role in regulating neurodegenerative processes in the retina in experimental glaucoma condition. Increased neuroserpin expression may therefore be beneficial in glaucoma and will be the subject of further studies. At last, I would like to thank my supervisors, Professor Stuart Graham, Associate Professor Vivek Gupta, and Dr. Nitin Chitrashi for their guidance, and my team for their continuous support. Thank you.
Hello, everyone. My name is Deus Vigrimana, and I am Research Fellow at Eye and Ear Hospital in Melbourne, Australia. I have no conflict of interest to declare. Intraocular pressure has been consistently demonstrated to be associated with the incidence, the prevalence, and the progression of glaucoma. Recent studies have emphasized that IOP remains the main risk factor for glaucoma and the basis of its treatment. For instance, each 1 millimeter increased IOP is associated with 10% risk of developing glaucoma and 13% of progression. On the other hand, a 1 millimeter IOP reduction with treatment is associated with a 10% decrease in the chance of progression. The Barbados study has proven that IOP is higher in glaucoma patients of African descent. In this population, glaucoma occurs earlier and progresses rapidly compared to a Caucasian population. The purpose of this study was to evaluate the barriers to intraocular pressure measurement in Burundi, advocate for change, and promote learning and global collaboration to overcome these barriers. 36 eyes were identified throughout the country. A Google form questionnaire was designed and sent to one eye care provider of each clinic via WhatsApp through a dynamic link. Identity of participant and names of the clinic were not recorded for confidentiality purposes. The reason of practice, the professional title, the type of tonometer, and the reasons for IOP measurement were recorded. Participation rates were 83%. The majority of participants were based in the capital city. 1 in 4 participants were ophthalmologists. This pie chart shows that 1 in 3 eye care services in Burundi are not equipped in tonometers, and that only 1 in 10 eye care professionals in this survey declared measuring IOP routinely for each patient attending the clinic. The remaining measure IOP in the presence of optic disc abnormality, history of glaucoma, at patient requests, or past medical history. The most common used tonometer were Goldman applanation and shots, followed by Pulse A, Tonopen, and eye care. In conclusion, the most common barriers to IOP measurement in Burundi were insufficient awareness of glaucoma and the lack of adequate resources. This data was used to raise awareness of glaucoma and advocate for policy and practice change. It is an evidence of how challenging is management of glaucoma in the developing country, where basic equipment such as tonometer still not available. Although not all glaucoma patients present elevated IOP, Those with high IOP are at the highest risk of progression. In the underserved population, identifying those at highest risk of blindness from glaucoma is a priority. Tonometry should be performed routinely for each patient attending an eye clinic. Thank you so much for your attention.
Good afternoon. I'm Minisa from South Korea. It is a great pleasure to be part of the World Glaucoma Congress 2021. Today, I'm going to talk about optic disc microvascular dropout detected by Swepser's OCT angiography. Recently, optic disc microvascular dropout, defined as a complete loss of vessels within the optic nerve head, was reported by using OCT angiography. However, the current OCTA is limited in visualizing deep optic nerve head vessels due to poor visualization of the anterior lamina curvosa by shadowing or limited penetration in some eyes. In these circumstances, Swepser's OCT angiography was reported to provide better penetration, faster scan speed, and more detailed imaging of the deep optic nerve head vessels. So this study was aimed at investigating the ability of Swepser's OCT angiography in visualizing optic disc microvascular dropout and to assess factors associated with the MVDD in POAG eyes. The optic disc microvascular dropout was determined on the temporal area of the optic nerve head based on the qualitative analysis of the whole signal mode SSOCTA, showing all OCTA signal below ILM surface. When the three groups were divided, eyes without dropout had preserved optic disc vessels. An MVDD group had complete loss of OCTA signal below ILM surface, and in discernible MVDD group, anterior laminar surface was not visualized due to shadowing by neural rim or vessels, or limited penetration. Other parameters, including focal LC defect and perpapillary deep microvascular dropout, were assessed, and their relationship with MVDD were evaluated. Here are the results. Among 195 eyes with tolerable OCTA quality, determination of the dropout was possible in around 84%. And only 16.4% were categorized as indiscernible MVDD group. And these eyes had significantly lower ASCO area than the other two groups. So caution is needed in assessing optic disc vessels in eyes with small optic disc. Moreover, the current study achieved relatively lower rate of eyes categorized as indiscernible MVDD group by using Swepser's OCT angiography compared with the previous study using spectral domain OCTA. So this implicates the clinical utility of Swepser's OCTA in assessing deep optic nerve head vessels. When other parameters were compared, eyes with MVDD had worse glaucoma severity and higher prevalence of perpapillary deep layer microvascular dropout and focal LC defect. Similarly, in the multivariate logistic regression, focal LC defect and MVDP remained as factors strongly associated with MVDD. Here's the representative case. The two eyes had similar degree of glaucoma severity and IOP parameters. On the left side, an eye without focal LC defect had MVDP and preserved optic disc microvasculature. Meanwhile, an eye on the right, having focal LC defect and MVDP in the infratemporal area, showed well-defined optic disc vessel damage in the corresponding sector. These findings concur with previous studies showing the relationship of optic disc microvascular dropout to the damages of lamina curvosa and parapapillary deep layer microvascular. To summarize, Swepser's OCT angiography enabled determination of the optic disc microvascular dropout in more than 82% of POAG eyes. And this dropout was strongly associated with glaucomatous damage of parapapillary vessels and lamina curvosa. So these results highlight the clinical utility of Schweppes OCTA for in vivo assessment of the deep optic nerve vessels. Further longitudinal studies to elucidate the pathogenic role of the vascular damage are warranted. Thank you for your attention.